I want you to think about the last time you walked into a room and completely forgot why you were there, or the moment you were introducing an old friend to someone new and their name just wasn't there. It happened, and for a second, something cold moved through your chest. Most of the time, this is nothing. This is just being human, being tired, being distracted. But for millions of older adults, that small moment turns into something much heavier. It turns into a thought that arrives uninvited, usually late at night, usually alone. Is this it? Is this where it starts? I want to tell you about a woman named Carol. 73 years old, sharp as anyone I've ever met, ran her own bookkeeping business for 30 years before she retired. Over about 8 months, her daughter, Beth, started noticing small things. Carol was repeating herself in conversation, asking the same question twice within the same phone call. She got lost driving to a grocery store she'd shopped at for 20 years and had to pull over and call Beth for directions. She seemed flatter somehow, quieter, like some of the light had gone out of her. She stopped calling her grandchildren as often. Beth brought her in for an evaluation. Carol's family doctor ran a standard cognitive screening and a basic blood panel, and the phrase that came back was the phrase every family fears most: possible early cognitive decline, likely dementia. Beth did what a lot of us would do in that moment. She started grieving the mother she thought she was slowly losing. She looked into memory care facilities. She started having the hard conversations with her siblings about what came next. Here's what I need you to understand, and I need you to really sit with this. Somewhere between 10 and 30% of people evaluated for memory problems, depending on which study you look at, have something else going on underneath the surface. Something that looks like dementia, acts like dementia, and gets misdiagnosed as dementia, but is not dementia at all. In the medical world, we sometimes call this a reversible dementia or a dementia mimic, and one of the most common, most overlooked causes of it is a deficiency in a single vitamin, B12. This is not a fringe theory, and it is not something I'm telling you to scare you. It's documented in mainstream medical literature going back decades, and the reason it gets missed as often as it does isn't because doctors don't care, or because anyone is hiding anything from you. It's because of how the testing system is built, and how symptoms of B12 deficiency can look, on the surface, almost identical to symptoms of cognitive decline. Stay with me, because by the end of this video, you're going to know more about this connection than most people walking out of a routine physical. And if you, or someone you love, has been told it's probably just aging, or it might be early dementia, this could genuinely change the next conversation you have with a doctor. I'm Dr. David Thompson, and this is Senior Health Guide. Let's start with something that genuinely surprised me the first time I came across it. In the United States, a blood test showing a B12 level of around 200 picograms per milliliter is typically flagged by the lab as within normal range. No red flag on the chart, no note to the doctor, nothing that prompts a second look. But in Japan, and in several other countries, the threshold used to define a concerning B12 level is set much higher, often around 500. For years, researchers who study B12 and neurological health have pointed out that the American reference range was established primarily to prevent a blood disorder called megaloblastic anemia, not to protect against the neurological and cognitive symptoms that can show up at levels most U.S. labs would still call fine. This matters more than it sounds like it should, because B12 doesn't just cause fatigue when it drops. At the levels we're talking about, it can begin to affect myelin, the protective coating that insulates your nerves. It can affect the production of neurotransmitters your brain relies on to think clearly, to stay emotionally steady, and to process information at normal speed. And when all of that starts to shift at once, it can produce a clinical picture that overlaps, symptom for symptom, with early dementia. A doctor glancing at a lab printout that reads normal has no built-in reason to keep digging further. So in a meaningful number of cases, the real underlying cause slips quietly through the cracks. Now let's talk about why this happens so much more frequently in people over the age of 60, because the answer isn't about willpower or diet, it's about basic biology. It comes down to something called intrinsic factor. I want you to think about B12 absorption like a locked door. The B12 sitting in your food, in your meat, your eggs, your dairy, is the key. But that key cannot get through the door on its own. Your stomach has to produce a specific protein called intrinsic factor, which acts almost like the door frame that holds the lock in place, and stomach acid is what allows that entire mechanism to function correctly in the first place. As we age, a large number of people gradually develop a condition called atrophic gastritis, a slow thinning of the stomach lining that reduces the stomach's acid production over time. Less acid means intrinsic factor doesn't work as efficiently, which means a person can be eating a genuinely excellent diet, plenty of protein, plenty of B12-rich foods, and still become deficient. Not because their choices are wrong, but because their body has quietly lost some of its ability to unlock the B12 that's already sitting right there on the plate in front of them. And here's the part that catches even more people off guard, myself included when I first learned it. Two extremely common medications appear to make this worse. Metformin, one of the most widely prescribed medications on earth for managing type 2 diabetes, has been shown in a number of published studies to interfere with B12 absorption when taken over the long term. And proton pump inhibitors, the acid-reducing medications many people know by brand names like Prilosec or Nexium, work specifically by lowering stomach acid, which is exactly the mechanism B12 absorption depends on to begin with. If you are over 60 and taking either of these medications, I want to be very clear. I am not telling you to stop taking them, and you should never adjust a prescribed medication without your doctor's guidance. What I am telling you is that this connection is worth raising directly with your doctor, specifically so B12 status can actually be on their radar going forward. So how do you know if any of this might apply to you or to someone you love? Let's walk through 5 things I want you to genuinely pay attention to over the next week. The first is what I call the brain fog curtain. This is different from ordinary everyday forgetfulness. Ordinary forgetfulness is misplacing your glasses and finding them on your own head 10 minutes later. What I'm describing here is a heavier, thicker kind of fog. Difficulty following a conversation that used to be effortless. Losing your train of thought in the middle of a sentence more than once or twice a week. A sense that there's a thin curtain hanging between you and your own thoughts, like you can feel the idea but can't quite reach it. This pattern has been associated in research with changes to myelin, the coating around nerve fibers that B12 helps the body maintain and repair. The second is a sensation some patients describe to me as an electric shock. In clinical terms, this is peripheral neuropathy, a tingling, pins and needles, or burning sensation that typically starts in the toes and the balls of the feet. Patients often tell me it feels like their foot fell asleep and simply never fully woke back up, no matter how much they shake it out or change position. This tends to happen because B12 deficiency affects the longest nerve fibers in the body first, and the nerves running down into your feet are about as far from your brain and spinal cord as nerves get. The third is something I call the unsteady walk, and families very often mistake this for simple weak legs or normal aging. What's actually happening in many of these cases is a loss of something called proprioception, your body's built-in sense of exactly where your feet are in space without needing to look down and check. This can show up as bumping into door frames that have been in the exact same place for 20 years, feeling unusually wobbly going up or down stairs, or a general sense of being less steady on your feet, especially in dim lighting or in the dark. This is not primarily about muscle strength. It's about a nerve signal from the feet that isn't reaching the brain clearly anymore. The fourth sign is one you can actually check for yourself right now, and I genuinely want you to go look in a mirror after this video ends. It's called glossitis. A tongue affected by significant B12 deficiency can look unusually smooth, take on a deep red or almost beefy color, and lose the tiny bumps, called papillae, that normally cover its surface and give it texture. It can also feel sore, or become unusually sensitive to hot, spicy, or acidic foods. Of everything on this list, this is one of the more specific physical signs a doctor can actually look for and document. And the fifth is what I call the unexplained dark cloud. B12 plays a real, documented role in the production of dopamine and serotonin, the neurotransmitters most closely tied to mood, motivation, and emotional steadiness. A sudden onset of low mood, flatness, or new anxiety in someone who has never really struggled with their mental health before can look, from the outside, almost identical to the apathy and social withdrawal that shows up in early dementia. Families see it happening and think they're slipping away from us. What may actually be happening in some of these cases is a treatable chemical imbalance rooted in something as simple as a vitamin level. If any of this is sounding familiar to you right now, take a breath with me for a second. This is not a diagnosis, and I want to say that plainly. Having one or two of these symptoms does not mean you have dementia, and it does not automatically mean you have a B12 deficiency either. What it does mean is that this is genuinely worth a real conversation with your doctor, and specifically worth asking for the right tests, because in a lot of cases the standard test alone isn't quite enough to catch this. So let's talk about what actually helps, because here is the good news in all of this. Unlike many causes of cognitive decline, this particular cause, when identified and addressed in time, is often treatable, and many people do see meaningful improvement in their symptoms once treatment begins. That doesn't mean every case resolves completely, or that every symptom is guaranteed to reverse, especially if nerve changes have been present for a long time, but it means this is genuinely worth pursuing. On testing, ask your doctor not only for a standard serum B12 level, but specifically for a methylmalonic acid test, often abbreviated as MMA. Here's the simple version of why that matters. B12 is required for a specific chemical reaction happening constantly inside your cells. When B12 is genuinely low at the cellular level, a byproduct called methylmalonic acid builds up and becomes measurable in the blood. Many clinicians consider this a more sensitive marker of true cellular deficiency than the serum B12 number by itself, especially in older adults whose serum levels can sit in a borderline, seemingly normal range, even while real symptoms are already present. On treatment, if someone's underlying problem is in the stomach, in that intrinsic factor pathway we talked about earlier, then simply swallowing a standard B12 pill doesn't necessarily solve anything, because that pill still has to pass through the exact same broken absorption route to do any good. This is why many clinicians recommend one of two alternate delivery methods instead. The first is sublingual methylcobalamin, a form of B12 designed to dissolve directly under the tongue, where it's absorbed straight through the tissue there, bypassing the stomach's locked door entirely. The second, typically reserved for more severe or more clearly neurological cases, is a B12 injection given directly into the muscle. Injections bypass the digestive system completely, which allows levels to rise more quickly under a doctor's supervision, and it's why many consider this the gold standard for symptomatic cases. One more thing worth knowing, this isn't a one-and-done fix. Whether someone ends up on sublingual B12, regular injections, or both, doctors typically recommend rechecking levels periodically, often every few months at first, to make sure the numbers are actually moving in the right direction and the dose is working the way it should. And because atrophic gastritis and medication effects tend to be ongoing, this is usually something managed for the long term, not a short course you finish and forget about. That's not bad news. It just means the follow-up appointment matters almost as much as the first one. I also want to say a word about food, because I don't want anyone walking away thinking diet is irrelevant here. Foods like clams, beef liver, fish, eggs, and dairy are genuinely rich sources of B12, and for people whose absorption is working normally, diet alone can go a long way. But for someone whose intrinsic factor pathway has weakened with age, or who's on one of the medications we discussed, diet alone often isn't enough to correct an existing deficiency, which is exactly why the sublingual or injectable routes exist. This isn't about replacing good nutrition. It's about recognizing when good nutrition needs backup. I want to go back to Carol for a moment, because I think about her family often. Beth, after learning some of what I've shared with you today, went back to Carol's doctor and specifically asked for a methylmalonic acid test alongside the standard panel that had already been run. Carol's results came back showing a genuine cellular B12 deficiency, and given her combination of symptoms, her doctor started her on a course of B12 injections under close medical supervision. Over the following months, Beth told me she started to see her mother come back to her, more present in conversations, steadier on her feet on the stairs, more like the woman who used to run circles around all of them at the dinner table. I share this story with you not to promise you the exact same outcome, because every case is genuinely different, and B12 deficiency is only one of several possible causes behind symptoms like these. I share it so you understand why asking the right question at the right appointment can matter more than people realize. If this video is resonating with you right now, or if you're already picturing a specific parent, spouse, or friend in your mind as you listen to this, go ahead and type the word vitality in the comments below. I read every single one, and it helps me understand that this information is actually reaching the people who need it most. Before you go, I want you to do two specific things. First, if you or someone you love is over 60 and has noticed any combination of the symptoms we've covered today, memory changes, tingling in the feet, unsteadiness on stairs, new mood changes, or that smooth, beefy red tongue, I want you to write those symptoms down. Bring that list, along with a specific request for a methylmalonic acid test, to your next doctor's appointment. Don't just describe the symptoms in general terms. Ask for that test by name. Second, share this video with someone. Not because I need the views, but because somewhere out there, right now, a family is quietly grieving a diagnosis that might not be the whole story, and this could be the exact video that changes their next conversation with a doctor. Don't let a treatable deficiency get permanently mistaken for an irreversible disease. If this video helped you today, type the word independence in the comments. Subscribe to Senior Health Guide so you don't miss what we cover next, and I'll see you in the next one. I'm Dr. David Thompson. I'll see you in the next video.